Good morning, everyone. Welcome all of you joining our public presentation organized by the Occupational Health Center. Today's topic is about long COVID. What is the resources and strategies to manage? We are so pleased to have Dr. Aaron Kraut. He is the Medical Director, Occupational Health, Winnipeg Regional Health Authorities Integrated Site, and also along with Rukmali Mendis. She is the certified respiratory educator, chronic disease management clinicians in the Winnipeg Regional Health Authorities. Before we start the session, we would like to acknowledge that we are gathered on Treaty 1 territory, and that Manitoba is located on the territories of the Anishinaabe, Anishinaabe, Dakota Oyate, and the Dinisunini, Inuit, Nehatukwa nations, and on the national homelands of the Red River Métis nations. We acknowledge that northern Manitoba includes territories of the Inuit. As we together on Treaty 1 territory, we acknowledge Treaty 3 territory, in particular Salt Lake 40 First Nation, the source of Winnipeg's clear drinking water. We also acknowledge Treaty 5 territory, including Nelson River, which provides us with access to most of our electricity. The Occupational Health Center acknowledged the devastating, lasting, and ongoing impacts of settler colonialism on Indigenous people and a deep lack of action toward truth and reconciliation. OHC has embarked on a process of learning about the Indigenous people's history and culture, and also our role as settler with our staff, board, and volunteers under the guidance of the knowledge keeper, Clayton Sandy. We commit ourselves to active accountability, truth, justice, equity, and reconciliations. If some of the folks that haven't participated in our webinar before, so please put your comment and question on the chat area, and the presenter will answer at the Q&A session. This event, you saying that is being recorded, you'll be able to review it after that, and you could share with some folks that missed the session today, and also we're going to share on our website and social media. Please connect with us. We cannot cover all the questions at the Q&A, then just email with us, you have more questions. And if some people doesn't know about OHC, so the Occupational Health Center is a community health center funded by the Winnipeg Regional Health Authorities. So we are located on 167 Sherbrooke Street. We provide all the services to Manitoba workers with work-related health issues. We also work closely with joint workplace health and safety committees for training. So please visit our website for more information. And also all our services is free and doesn't need referrals to see our physicians here. And before we get started, I just want to read a short bio for Dr. Aaron Kraut and Rukmali. So Dr. Kraut is Associate Professor at the University of Manitoba in the Department of Internal Medicine and Community Health Sciences. Dr. Kraut has practiced clinicians, occupational medicine in Winnipeg, both at the Health Science Center and at the Occupational Health Center. He has been as attending physician on the internal medicine clinical teaching unit at the Health Science Center for 30 years. Dr. Kraut has also the medical director of occupational health at the Winnipeg Regional Health Authorities Integrated Site. Rukmali Mendis. She is a physiotherapist and certified respiratory educator with the WRHA Mind Health team located in St. Boniface and Singapore areas since the initial months in the COVID-19 pandemic. Rukmali has been receiving referrals from primary care providers in the St. Boniface and St. Martel areas for those patients experiences ongoing symptoms after having COVID-19. Rukmali provides individualized one-to-one treatment as well as facilitate group education section through the WHA for long COVID symptom management. Today, Rukmali will talk about some of the most common symptoms associated with the long COVID, and also will share some available resources to help those who are dealing with these conditions. Now, this is the time to join me to welcome to presenter. Dr. Kraut is going to present first, and then followed by Rukmali. So now I'm going to stop screening.
Thank you very much, Tiffany, for that good introduction. I'll try to share my screen here. Can you see my slides now?
Yes, but you need to put on the slideshow.
There we go. Okay.
There you go. Good.
It's good? All right.
Yeah.
So thank you for that introduction. So as mentioned, we're going to be talking a little bit about long COVID today. I'm going to talk a little bit about the epidemiology of COVID, and then some of the health problems associated with, and then some of the things that one can try to do to avoid getting long COVID, and also some of the points in trying to recover from long COVID and getting back to as normal function as possible. So the first slide I have here is just asking how common is or was COVID in Canada. Now, there's two lines here. You know, for the first couple of years with COVID, we had pretty good information on how, at least on how many people might have been diagnosed, because it was quite common to do testing and in an official lab. However, after you know, for the last couple of years, though, official statistics on how common COVID is really don't exist, because there's first of all, a lot of people were self-testing at home, and now testing isn't as available. So we really don't know how much COVID there is. So it's clearly a lot more than, you know, almost none that's been reported here. For hospitalizations, though, I think the data is a little bit better. This is from Health Canada, and it's a slide of the number of people hospitalized with COVID over time. The same, a bit of concern in the gray area, and here it's broken down by age groups. And you can see the darker green ones are the older age groups. And again, you can see for hospitalizations, it's people over 80, people over 70 in their 70s, and people in their 60s make up most of the people who are hospitalized with COVID now. ICU, similar, the numbers are lower, but a similar trend that it's most common in the people in their 70s and 80s that get admitted to the ICU. And deaths, again, similar. Most of the deaths are in people in their 70s and 80s. So I pulled this slide just talking about how common is COVID now in Canada. This is from the middle of August, sorry. And one can see this is the readings in Winnipeg and in Brandon. And we're moderate to high, which is sort of like most of the rest of the country still. So it really hasn't disappeared, although I think collectively the attitude towards COVID has changed considerably over the past number of months. So how likely is it to have had COVID in Canada? This is a slide from just over a year and a half ago. And they in this data, anyone who had blood tests, they anonymously took a sample of the blood and tested it for antibodies against COVID. And you can see by in the Omicron wave here that by early January 2023, about 75% of people had antibodies that's shown that they had been infected with COVID. And almost 100% of people had antibodies showing whether they were infected or vaccinated. That's this top line. Currently in Manitoba, this is a slide of our respiratory outbreaks. So week 1 is January 1st, and week 27, I think, is July 20, the start of July. And the green is COVID, the orange is other respiratory, and the blue is influenza. And again, you can see that we're still having some outbreaks with COVID. In the summer, there's not much with influenza, and other respiratory viruses are sort of in the middle. And in fact, this year, it looks a little higher than it was last year. Okay. So COVID has a wide spectrum of conditions associated. Many people have asymptomatic infections. Some people, in fact, most people probably have a fairly mild illness that doesn't require them going to the emergency room or going to the hospital. But some people do have a severe illness requiring hospitalization, and in some cases it leads to death. So whole spectrum there. What is long COVID? Well, it's
Alan, your microphone went mute.
Yeah.
Can you hear me again?
Yes.
Yes, it's good now.
Yeah, okay, sorry. So I'll just start with this. I think I moved something, so I might have changed.
Yeah, just this slide.
This
Yeah.
one. Okay, so basically it's what is long COVID, and part of the problem is that there's no clear, widely accepted single definition. So the World Health Organization calls it the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with these symptoms lasting for at least 2 months with no other explanation. The U.S. Department of Health and Human Services says long COVID is not one condition, but it represents many potentially overlapping entities, likely with different biologic causes and different sets of risk factors and outcomes. So it's, according to the U.S. Department of Health and Human Services, it's really a mixture of a variety of diseases, and that's why a variety of approaches are needed. And what is good for one etiology might not be good for another etiology. So long COVID is a mixture of really 2 different sets of problems. One is, as I mentioned before, there's some people hospitalized and they have documented organ damage due to COVID, and it's not surprising that they might have long duration of symptoms. There's another group, though probably more of the people with long COVID don't have clearly documented organ damage, and there's a number of theories for why their symptoms might be ongoing. One is that there's viral persistence, reactivation of latent viruses is another, changes in their immune system or autoimmunity triggered by the infection, or chronic blood clotting problems are some of the theories. And for some people, maybe one and not another. So when COVID presents, if you look at the papers on this, they really talk about all organ systems, 12 organ systems in the body being affected, and 200 different symptoms. However, the most common would be post-exertional breathlessness, cognitive impairment or brain fog, headache, and fatigue. However, one can have GI and cardiovascular, respiratory, nervous, and mental health symptoms associated as well. So it's really, really broad in the symptoms, and because of that, one needs to take different approaches to treating individuals who have this condition. Okay, so how common is long COVID? Well, the prevalence rate for people vaccinated is between 10 and 12%. It's between 10 to 30% of non-hospitalized cases, and much higher in hospitalized cases, between 50 and 70%. But because most of the people with COVID aren't hospitalized, in fact, non-hospitalized cases make up the majority of cases of long COVID. The CDC and the state's household survey said that about 15% of US adults reported having experienced long COVID symptoms. And they also reported that in June 2023, it was 6% of adults, and that had fallen from 7.5% a year prior. Among people that indicated that they had COVID, 11% reported that they have ongoing symptoms, which fell from almost 19% a year prior. And of people with long COVID, approximately a quarter of them said that they had significant impairment. So again, it's a significant number of people. You know, a quarter of 6% is 1.5%. And if there's, let's say, 350 million people in the US, that's like 3.5 million people. So that's a lot. A recent paper came out in Nature that estimated that there were 400 million people worldwide that had long COVID, and that its economic impact was one with 12 zeros behind it. That's $1 trillion, and that amounted to 1% of the global economy. So that, again, a lot of people may have this. Well, how can we go about not getting long COVID? Well, the first thing to do is try not to get COVID itself. And vaccination has been shown in Sweden to decrease the likelihood of getting post-COVID. The more vaccines people had, the less likely they were getting. And with people who had 3 or more vaccines, 73% less likely. Part of the issue with this kind of study is that as the vaccines pulled out, the variants of COVID changed as well, and maybe the more recent ones are less likely to lead to long COVID. Also, Paxlovid was shown to decrease the risk of long COVID by 26%, and Paxlovid also decreases the risk of hospitalization and severe disease in very susceptible people. So that might be why that helps. So how are we doing in Manitoba with vaccine against COVID? So here are our numbers from 22 to 23, 23 to the end of August so far, and the last 6 months. So again, most of our COVID vaccines happen in the fall, which is why the last 6 months numbers are pretty low. And in fact, now it's difficult to get vaccinated against COVID unless you're deemed to be high risk. And the new vaccine is hopefully coming out shortly in the fall. But if we look at for last year, really only about 20% of the population were vaccinated, and just under 60% of the people over 65 were vaccinated. So clearly, when vaccines work, increasing vaccination should help us prevent long COVID. So what are some of the risk factors for long COVID? Well, women are thought to be more at risk than men. Older people, smokers, people who have high body mass, and people who have a variety of underlying diseases like diabetes or chronic pulmonary disease or asthma. I mentioned vaccination decreases the risk of long COVID. The more severe the infection, the more likely it is. And people who had a second infection seem less likely to get it than after the first infection. So for treatment, well, unfortunately, there's no definitive treatment for long COVID because there's a variety of postulates and what may lead to it. So there's not going to be one treatment. Care is directed towards symptom management, rehabilitation, and reassurance and support, and that's something that Rukmali will be talking a little bit more about later. If there's cognitive dysfunction, then cognitive pacing may work. If they have postural orthostatic tachycardia, so when they stand up, their heart starts racing, beta blockers might help. Physical activity as a general treatment, though, hasn't been shown to be effective, and in fact may worsen the condition in a number of people, particularly those that have post-exertional malaise. So you have to go with pretty gradual if you're using physical activity, particularly in those people. And basically on that point, we need some more research on how to safely return people to physical activity without worsening their symptoms, because lying around and doing nothing is also not good for people. So how do we go about preventing work disability? Well, the important thing is to prioritize functional outcomes. So trying to get people back to work is quite important. The importance of work to worker well-being is key. So again, getting people back to work in a gradual way is what we're going to be talking about. Trying to get them to do some things, not everything at work is important, and arranging the work around their capabilities is very important. And again, work is very important to all of our health, to everyone's health, and getting people back to work or returning to work is important for people with long COVID for a variety of reasons. Now, it's important when we're trying to get people back to work that we look at all the other factors that threaten participation in work. Which means some of the things at work and in their personal life that might be affecting them, as well as their disease. So some of the non-clinical factors that may prevent people getting back to work is a lack of accommodations at work, limited access to vocational rehab, and sometimes the individual's difficulties overcoming their health challenges. And then certainly there are the worker's emotional status, and personal factors may also complicate getting people back to work. When I look at work, getting people back to work, I think of a three-legged stool, with one leg being the disease, one leg being the workplace, and the third leg being the worker. And if only two of these are sort of positive for getting some back to work, it doesn't work. Sometimes the disease is so severe that the person can't get back to work. Sometimes the workplace isn't accommodating or isn't trying to help people back to work. And sometimes individuals have, for a variety of reasons, their personal conditions are making it harder for them to get back to work. So for return to work, I think the people with long COVID often have experienced difficulties in coping with their symptoms and returning to work. And because of that, we have to sort of modify their return to work program. Getting people back to work as soon as possible is beneficial for them. But we have to recognize that if we try returning people to work with long COVID before they're ready, that can result in some deterioration. So there's a real balancing act here. Because of the prolonged reconditioning and frequent post-exertional malaise, we have to use a gradual work titration, and that can be really quite slow in some cases getting people back to work. It's not a matter of maybe 1 or 2 weeks, but you should try for a few weeks and then update it accordingly on how someone's doing. Now, to do that, you have to understand the essential duties of the job. And that's the first thing when you try to get people back to work. There may be some things that are easier for them to get back to than others. And that's something when sending someone back to work, you have to understand. You also have to recognize that each person with long COVID is really different, and their symptoms may be different. And because of that, they need a personalized approach to returning to work, particularly when they do hard, strenuous physical work. People have fatigue, may have to be restricted from work that's not highly paced or does not require large levels of physical exertion. And people with sleep disturbances, maybe you could give them a later starting time. People who have cognitive impairments shouldn't do safety-sensitive work. And as their symptoms change over time, it might be necessary to adjust their work prescription to get for a worker with long COVID, also adjusted over time. So I think that's what I had. This is a particularly good reference I found on this topic if someone wants to look it up. And I will pass it over to Rukmali now and look forward to trying to answer any of the questions that you may have. So I'm going to stop sharing. Okay.
Thank you, Alan.
You, Alan.
I'm going to try sharing my screen.
Good.
Okay, good.
Yeah.
All right. Hang on one second, just have to adjust something here. Okay, so my name is Rukmali, and thank you for the great introduction there and for inviting me here today to meet with you all. So I'm going to talk more about some of those common symptoms and some resources. So first of all, we'll just do a little bit very quickly about what are some of the reasons for having those ongoing symptoms after having COVID. And then we'll go into 3 of those common symptoms that Alan mentioned. We'll talk about some strategies that people can use at home and at the workplace, and share some resources that we find in Manitoba that could help, as well as some online resources. And we're hoping to have some time for questions at the end. So 4 years since the pandemic started, and with the help of vaccines, most people who get infected with COVID-19 make a full recovery, which is reassuring. Mild and moderate COVID lasts about 2 weeks for those initial symptoms. But then there's those people who have experienced, they experience lingering health problems after those initial symptoms go away. And for those experiencing those long-term symptoms, that could be because of a few different reasons. So I have mentioned a few possible reasons here. One being, did they have a pre-existing chronic disease? So did they have something like asthma or COPD or hypertension, high blood pressure? And having COVID is a stress to the system. So having that extra stress can potentially make that previous illness worse, and possibly they didn't need any medication to manage that asthma or COPD that they had before. You know, they managed it with exercise, diet, and other strategies, but having COVID was enough of a stressor that disease is worse, and they do need medication. So that's one possibility. And for those people who end up in the ICU, which is a smaller proportion now, which is again reassuring, but there's something called the post-ICU syndrome that can lead to physical changes, cognitive changes, psychological changes that people may experience if in fact they were in the hospital in the ICU for COVID. So that's also a possibility. And then that organ damage. Some people can have organ damage following a severe infection. For example, damage to the heart, lungs, kidneys, for example. So it's important that you speak to your doctor, and the doctor or the primary care provider may send them for some testing to kind of check those organs. And that may look like an X-ray for the lungs, or blood tests, or testing for the heart, for example, to really see if there has been some damage to those organs. And then another reason for these persistent symptoms is what we're here to talk about today, is called long COVID or post-COVID. How is long COVID diagnosed? There's not one specific test you can do to say someone has long COVID. It's a clinical diagnosis. What that means is it's a process of identifying a condition or an injury based on the signs and symptoms the patient is having. So that's based on, you know, checking their medical history, doing a physical exam, and then you come to the conclusion that they may have long COVID. So the reason I include this is just to say that if someone's having ongoing symptoms, it's not always due to long COVID. It could be one of these other things that we may treat differently. So for the rest of the presentation, we're going to delve more into long COVID. Like Alan said, they've identified over 200 symptoms. Doesn't mean every single person with long COVID has all 200. Some may have a few and a handful of symptoms, and what it looks like changes from person to person. And people who experience both mild or severe COVID-19 can experience long COVID and long COVID symptoms outlined here. Now, I'll give you a little sample patient so you have kind of a sense of what this may look like. So here's a 60-year-old female who had COVID infection a couple of times. They didn't need to go to the hospital or the emergency department. However, they did see their family doctor and received some antibiotics initially. And they did make some gains. They did improve, but notice over time that they were still having symptoms even, 1 or 2 years later. So they went back to their doctor, and the doctor did send them for some blood work, chest x-ray, EKG, stress tests. Those were all normal, and that can be often the case for many people who have long COVID. Past medical history-wise, they were pretty healthy, was able to exercise, work full-time. They had some bronchitis 1 or 2 times a year, needing some antibiotics, but otherwise healthy. So by the time I was seeing them, they were complaining of some of those main symptoms that was on the slide before: dyspnea, meaning breathlessness, wheezing, coughing, feeling fatigued, brain fog, poor sleep, chest pain, palpitations, feeling dizzy, headaches, and ringing in the ear. And they were having lots of ups and downs and was feeling really, really discouraged because of these symptoms. They're still working full time, but getting sick often and then going back and forth, needing to take time off. So we're going to focus on some of the key symptoms. So 3 main ones being fatigue, cognitive dysfunction, and dyspnea. I'll focus on those for the remainder. In long COVID, fatigue is a primary symptom and has a significant impact on both productivity and quality of life. Fatigue is largely an invisible symptom of long COVID in that it's not easily obvious to those around us and can be incredibly isolating for the individual experiencing it. So, people around the patient might say, you look the same, you're just the same person. So, but how they feel is quite different. Fatigue is the feeling of extreme exhaustion and can feel like there's no more energy left. It's an overwhelming tiredness that's not proportional to the level of exertion or the level of activity, and is not easily relieved by rest. So for some, the word fatigue doesn't really quite do justice to the disability that they're experiencing. It's not the same as feeling tired at the end of the day. And it's not because they've done something big. It could just be after, some self-care, like having a shower and getting dressed, and they feel exhausted. Patients often describe fatigue as an overwhelming sense of tiredness with no obvious cause, feeling extremely tired after very little activity, and waking up feeling as tired as they did when they went to sleep. So when we're thinking about that patient that I talked about a couple slides ago, we often use, or with many patients, we often use the analogy of a battery. So if you picture like a cell phone battery, it's a helpful concept to describe energy and a way to it's a tool to manage fatigue. So we all have an internal energy reserve or battery. Over time, we learn about activities we do that can help recharge our battery, like resting, visiting with a friend, going outside, or relaxing. And then those activities that can deplete it. So in individuals with long COVID, it seems like it takes less activity to drain their energy battery, and it takes longer for it to recharge. So that's a good concept to kind of help people figure out how to bank their energy. It's important to realize that many factors can affect our energy levels. So these things can be active things that we do, like physical things, for example, going for a walk or dusting the house. But it could also be cognitive tasks. So things where we use our brain, like focusing, thinking, like paying a bill, for example. and also things that are social, like talking to a friend or family member. So on top of these active tasks, which are physical, cognitive, social, there's things that are passive. So those are the things around us that we're exposed to that can also drain our energy. For example, environmental things. So a loud, busy restaurant is very stimulating and require more energy. Social media, being exposed to media, news stories all the time, that can be draining. Emotional things. So whether it's positive or negative emotions can drain energy. Even self-talk. So if you're having constant negative self-talk or loss of a role, for example, before COVID, you were able to do a certain job or take care of your kids, and now you're having a hard time. So those things can be draining. Relational, having difficulty in relationships. So all these factors can kind of help us with our energy or drain us. So this is important to consider. Our interventions for fatigue largely focus on ways in which we can be strategic in our use of energy. For example, what are some strategies for pacing, prioritizing, planning, so we can use the energy we have more effectively? Implementing strategies to recharge our batteries throughout the day. That may mean you have to stop, rest, pause to recharge the battery before you can go on for the rest of the day. Another issue with another main symptom is cognitive dysfunction. So what is cognition? That means the processes in the brain that we use to think, read, learn, remember, reason, or pay attention. So people who have long COVID can experience changes to their cognition. And those changes can be on their attention or memory or executive function. So I think attention and memory, that kind of makes sense. Attention allows us to kind of focus in on something. It's like putting a spotlight on a stage during a show that allows the performer to stand out from the background. So that's what our brain does when we pay attention. Memory is our ability to learn, store, retain information, and then later retrieve it. What's executive function? So it's kind of our skill where we put all of this together. So it includes more complex skills like planning, focusing, remembering instructions, juggling multiple things, so multitasking. Executive function helps us plan for and accomplish any goal, big or small, in a flexible way. So the term used to describe changes in cognition is brain fog. So we can say cognitive dysfunction, or we commonly say brain fog. So brain fog can represent in a variety of ways. So it could mean fuzzy thoughts, slow thinking, poor concentration, periods of confusion, trouble with word finding, and mental fatigue. We've all likely had brain fog from time to time because it can occur due to a number of reasons, like a poor sleep or stress or feeling unwell, hormone changes. So it can be due to many things. However, in many of these situations, it passes as the reason goes away. Brain fog in long COVID is taking longer to resolve, and that may possibly be because the cause behind long COVID is not resolving quickly. So with our client that we heard about, she was feeling mentally slowed, having some memory issues, word finding difficulty, and she is normally a person who presents in meetings, but now is less vocal and kind of feeling not too confident about her abilities at work in that realm. So for treatment, we focused on teaching strategies to implement in their daily lives to compensate for and minimize the impact of brain fog. For example, taking some breaks throughout the day to recharge and kind of rest the brain, and then using alarms, reminders, lists, so that they can keep track of things. We also worked on reducing some demands at home and at work. Discuss other strategies like sleep hygiene, making sure they get enough rest. So prioritizing their rest time and sleep time so they're able to recharge better. and focusing on one task at a time. Simplifying the environment, so less distractions. So maybe you change the lighting, you turn off a radio in the background and things like that, so they can really focus on the task at hand. Another common symptom is dyspnea, or the feeling of breathlessness. So when we're seeing people in the community, often they've had testing done to make sure there's no underlying causes, but that is something you always have to consider to make sure that we rule that out. So some people with breathlessness may also be prescribed inhalers and puffers, but they don't tend to be effective unless there is some sort of airway issues, pathology that's behind it. So with the absence of underlying pathology, shortness of breath can be from a change in a person's breathing pattern, or we call that dysfunctional breathing. Breathing pattern is, are you breathing through your nose or your mouth? How fast are you breathing? How deep are you breathing? And what muscles are you using to breathe? So that's what we mean by breathing pattern. So examples of dysfunctional breathing pattern might be over-breathing. So you're breathing more than you need to. So you're resting, but you're breathing as if you're running up the stairs. Maybe it's shallow or faster than it needs to be. Maybe you're using more your upper chest as opposed to using the diaphragm, or it's irregular. So there's a variety of ways that the dysfunctional breathing can look like. What are some strategies for that? So for our client that she was feeling short of breath, we worked on some breathing techniques. So we talk about breathing through the nose if you can, breathing more into the diaphragm and keeping your upper body more relaxed. Then we might teach some other techniques like pursed lip breathing that they can use to kind of regulate their breathing as they're starting to be active. So working through and trying to fix that breathing pattern can be helpful. Now, I think Alan mentioned this a little bit too, that idea of post-exertional malaise. That's something you may hear, or we call that PEM, associated with long COVID. What is it? It's defined as an increase in fatigue and other symptoms. So even that breathlessness, brain fog, headaches, so increase in fatigue and other symptoms that comes on after what doesn't seem to be a lot of activity. And that activity could be not just physical, it could be cognitive, social, emotional. So any of those activities can kind of cause a worsening of the symptom. If you look at this little picture, it shows kind of a push and crash cycle. So you push yourself a little bit, you do something a little bit more than normal, your symptoms get worse, then you're having a crash. Things are worse, you can't do quite as much. And then by resting, you may recover. But that could be a really tough cycle for people because they're just kind of, it's like a bouncy ball going back and forth and not really seeing recovery. So studies show that among people who have post-COVID, up to 48% of females and 41% of males experience post-exertional malaise. So that's something to consider when you're thinking about resuming activities, whether at home or at work. So post-exertional malaise is that often delayed exhaustion that's disproportionate to the level of effort that's made. Like I said, we can sometimes call it a crash, and that crash can happen even 24 to 48 hours after the activity. So that can be sometimes hard to navigate because if you're having a tough day, that may be because of something you did 2 days ago. So that could be, you had a whole bunch of meetings, had some poor sleep, and now you're experiencing a worsening of symptoms. So when we think about our 60-year-old client dealing with long COVID symptoms for over 2 years, they've been trying to kind of go at the same pace at work and at home as pre-COVID, trying to exercise and hopefully get stronger. But because of post-exertional malaise, she's having to step back when her symptoms would worsen. So to help our client learn how to know what their energy limits are so they can stop and pace before having a crash, we started off by doing an activity diary so they can kind of write down some of the things that the symptoms and the things that they're doing on a day-to-day basis, so they can kind of see patterns of what's going on. Then you can see if you're having a worsening of symptoms, you can look back in your diary and see, okay, what did you do a day before, a couple days before, to start figuring out some patterns. What we then worked on identify when the fatigue is setting in, to stop, take a rest before going, and also to minimize, also to set some limits as to what they could do. So for exercise wise, going for walks and yoga, as opposed to doing a full-on gym workout with weights, for example. We worked on maybe changing some work meetings to being able to log on virtually, as opposed to driving or taking a plane to travel for work. So figuring out how to work within that energy battery that you have. Okay, so we've talked about this throughout, but what are some of the main strategies for home? So the WHO, the World Health Organization, recommends overall that long COVID rehab should include educating people about resuming their activities conservatively at an appropriate pace that is safe and manageable for energy levels within the limits of current symptoms, and exertion should not be pushed to the point of fatigue or symptom exacerbation. So that's what we've been talking about throughout the last few slides. So when you use more energy than you have, then you tend to have those symptom exacerbation. However, having said that, not everyone has that. Some people may not experience post-exertional malaise, and then they may be able to gradually increase. But you have to be more careful if you're having worsening of symptoms. So using strategies like pacing, so stop, rest, pace before you can carry on, before the fatigue sets in. Planning, so throughout the day, planning for balancing strenuous activity with less strenuous activities, switching from one type, like physical things, to cognitive things. So you can, let's say, from paying a bill to doing some housework. So you're kind of giving your brain a rest while you do something physical. And then prioritizing, figuring out what are the most important things that you need to get done, what can be delegated, what can wait for another day based on how you feel. You may have to adapt, change the activity a little bit. For example, using some of the tools in the kitchen, right? So a blender instead of chopping the vegetables yourself, or you may buy pre-cut vegetables for meal prep, or some prepared meals to kind of help out at home. Positioning, so having good positioning, keeping your body supported. So maybe you sit instead of stand to do some tasks. People feeling supported at home. So like I said, most long COVID symptoms are kind of invisible. Other people can't see that you're suffering. So just for people to feel supported, that may mean they get some peer support. They connect with other people who have long COVID symptoms so that they can see what other people are doing. And it's a common struggle, and that can be quite therapeutic. And other community supports. Physical activity, making sure it's symptom guided, that you're not going at the cost of making your symptoms worse. So pushing through doesn't always help in long COVID. With respect to work, all those things that we use for home, so pacing, planning, prioritizing, those all help. That helps to conserve our energy. Schedule breaks, so taking mini breaks, whether it's 2 to 5 minutes, and to check in, kind of do some breathing and pause before you go on. Are there environmental changes? So can you reduce the busyness in the environment, reduce distractions, reduce clutter, so it helps us focus, adjusting lighting, noise canceling headphones, those kinds of things can help in the workplace. Gradual return in a titrated manner within the person's capacity. and then reassessment to determine if that stage is tolerated. So if they're going from, working every other day to adding another day, then reassessing to see, is that causing that post-exertional malaise or post-exertional symptoms worsening, right? So reassessing to see if they're tolerating it. Based on the symptoms, because we saw that people can have a variety of symptoms that may come from different systems in their body, really to think about a multidisciplinary approach to care if people are having a lot of different types of symptoms. So that may mean their primary care provider, so whether it's the family doctor, nurse practitioners involved to manage them, they may send them for specialists like a cardiologist if there's specific heart-related symptoms to make sure those things are taken care of. And then your allied health team, so physiotherapists, occupational therapists, mental health supports, to help with those multifactorial nature of the symptoms. So because people may have physical symptoms, may have cognitive symptoms, psychological symptoms. So to kind of think about that team approach when you're looking at care plans. So that may mean that people access that through private insurance, right? If you have insurance that allocate for these types of health services from physio, OT, social workers, then use those. If someone's off work and they have a case manager, accessing programs where they're kind of looking at a multidisciplinary approach can be helpful. What are some of the resources that people can access? So I help run this long COVID self-management group through the WRHA. It's 8 weeks virtually. It's open to anyone in Manitoba. So anyone in the province who can either phone in or log on using a computer can come if they're having long COVID symptoms. We do have a session coming up in October. So I put down here the registration phone number. You can also go to this website here to log on and see more about the group. And you will hear in the group from a variety of health professionals. So physio, OT, respiratory therapy, dietitian, social work. So we really try to share different strategies people can use at home and at work on managing long COVID symptoms. Another place, if someone's having brain fog and fatigue, is Easy Street. So that's out of Misericordia. You do need a referral. So the self-management program that I just mentioned, that's you don't need a referral. You just can register yourself. But Easy Street program, you do need a referral from a healthcare provider. It's a multidisciplinary program with physiotherapy, occupational therapy, dietitian, and social work. There is a waiting list, but again, this is best, I think, appropriate for those people who are dealing with fatigue and brain fog type of symptoms. I work in a My Health team, so if that's another way to get multidisciplinary type of treatment for those complex people. If the patient has a primary care provider attached to a My Health team, then that patient can access services that are available through the My Health team at no cost. Manitoba Lung Association has a long COVID support group, and they meet virtually every other Thursday. So here's a link you can go to sign up for that as well. And that is that peer support. So that is connecting with other people who are having similar symptoms. Shared Health has a website on long COVID that goes through a lot of those symptoms that we talked about and strategies that can help. Another good website is Long COVID Physio website. There's lots of handouts in 60 different languages that sometimes I use so the patient can take these handouts back to their family and friends and workplace to even start to understand what some of the long COVID symptoms are and what the challenges are. Okay, that's it for me. So I'm going to stop sharing here.
Thank you, Dr. Kraut and Rukmali. Really appreciate, your both presentation is really, really informative and sharing lots of resources and great information to the folks here. So I have copied a few questions on the document. If you just take a look. Yeah.
Oh. Right.
So first of all, it's about your 2 slides you'll be able to share after.
Yeah.
Yes.
I'll certainly send you my slides and you
Awesome.
can send them out to the group. There's a question about prevention, and I'll sort of take a pass at that one. So I guess you could think of prevention in a number of levels. First of all, there's preventing getting COVID in the first place. So I guess that would be primary prevention. So again, we talked about vaccination being important. Also, working, improving ventilation where one works decreases the likelihood of spread of the disease. That would be something that's important. Once people are sick, making it easier for them to stay at home, so paid sick time for people so that they can stay home when they are sick. The recommendation still for COVID after you've had a respiratory illness is that you should wear a mask for a few days afterwards when you come back. There's been certainly a considerable decrease in the use of masking in our society over time, so I'm not sure how often that does, but that is still the recommendation. And for people who are particularly acceptable on, they may wear more masks more often before they're sick. Once people get COVID, well, I guess, we made a list of some of the risk factors for long COVID, and age and sex aren't reversible, but some of the other ones were where you have a variety of chronic medical illnesses, having them as well controlled as possible before you get COVID is I think, quite important, and would decrease the likelihood that you get very sick, and certainly decrease the likelihood that you're going to get hospitalized and have organ damage from COVID. And again, Paxlovid for people who are at high risk for disease is something that is useful. So those might be some of the things that I might talk about. Okay, I just see another question, but when should workers put in a claim for long COVID to the WCB? Certainly, anyone who has any condition and thinks that they're work-related, they can put in a claim for the apply for WCB benefits, and then the WCB will adjudicate the claim. And so one's free to do that. And I think it depends on, and the question is how successful workers with long COVID to make the case that COVID occurred due to occupational exposure. I think that is something that the WCB will adjudicate. Certainly if there's evidence of an occupational exposure and nothing else, then that makes it more likely. If there's exposures in the community, it makes it less likely. I don't have any specific information on loss of taste and smell due to COVID.
So I'll take that one a little bit. Okay. So when it comes to specific symptoms, if you are, or a family member, a friend, or someone is having specific symptoms like that you're needing to learn how to manage, I would suggest maybe registering for that group program, because we do go through some of these and give things for home. So one of the things that come to mind is even there's something called smell training, like finding some, citrus and like certain smells and smelling it to kind of get those systems working again. That's something. And food wise as well, like using different spices. So but I don't want to get into all of that here. But I would suggest if someone is dealing with a few different symptoms, then that group can be helpful. And then going to the Shared Health website as well, there'll be some specific strategies for things like that.
Yeah. The question on limiting access to Paxlovid, I'm not sure exactly how the decisions are made on this. I think that certainly it's been shown to be a lot of benefit in preventing hospitalization in people who are at high risk. I'm not sure how much the discussion for long COVID went into the decisions on making it more available. So I don't have a lot of more knowledge on that. I also think that with the more recent variants of COVID in circulation, the frequency of taste and smell, loss of taste and smell has gone down.
So do you have more questions for Dr. Alan Kraut and Rukmali? So is anyone have questions and comment? Please put on the chat.
What I might do is I might share my email here too. If someone has some specific questions and need a specific resource, maybe.
That's great. Thank you.
Yeah.
Yeah. So I think this is the time to wrap up the session. Yeah. Once again, thank you, Dr. Kraut and Rukmali for this really great information session you provided to us. Oh, this is another question. I'm not quite sure. Carla, you submit the questions. What is it about? So I don't think I have your questions here.
Oh, there's a question I think Carla asked, is long COVID recognized as a disability?
Yeah.
Where the diagnosis would access to accommodations? That is my understanding, Alan. Can you correct me if I'm wrong?
Yeah. I think so too, but I'm not, I don't do a lot of work in the disability area. I think a lot of it depends on the individual plan that someone's involved with and how they deal with that.
Yeah.
Okay.
Okay.
That's it.
Great. One more comment. Thank you. Yeah. So I'm going to send all of you the recorded session and the slide. Thank you all the folks for your participation and great question you put out. So thank you so much. So you guys have a great fall. Then we will see you the next session that will be scheduled for October 8th. So I will send you all those information to the folks. Thank you. Have a good one. Bye-bye.
Bye-bye.